When I was in my final year of thoracic surgery residency, the Department of Pulmonary Medicine called to inform me that there was an elderly 91-year-old lady that needed a chest tube placed for pneumothorax. Normally, a pneumothorax is a condition when you have abnormal air in the pleura or the sac surrounding the lung. In some cases, pneumothorax is an emergent condition when you have to put a needle to decompress it rapidly. Fortunately, in this patient, this was not the case, and the patient needed just a chest tube within a couple of hours. I went to the floor and saw a frail, elderly lady that was a little bit disoriented. I checked the x-ray, and there was a left-sided pneumothorax that definitely needed chest tube placement. I talked to the floor nurses, and they gave her some medication to calm her down, and I started to prepare for the chest tube placement. Everything went fine, although not instantly better. The patient was okay, so I returned to my floor to continue my duty assignments. 2 hours later, the physician called me again and asked me to return to the floor immediately. He showed me the x-ray of the patient that I treated. I looked at the x-ray and immediately knew what happened. I had put the chest tube on the wrong side. I felt terrible. I had failed my patient. I compromised her life. The physician was actually very friendly, and he asked me to just put a chest tube on the other side, and he also promised he would not tell anybody what had happened. It did not help my emotional state, even though he was very kind and very encouraging. After putting the chest tube on the proper side this time, I went to my program director and immediately told him what had happened. My boss wasn't happy, but he wasn't angry either. He just told me to be more careful next time. This incident gave me a new perspective on things. I am indeed a human being, and I do make mistakes. We all do. In fact, the proverb, "To err is human," is over 2,000 years old. To Err is Human is also a title of a report by Institute of Medicine from the year 2000. In this publication, there was almost 100,000 deaths attributed on an annual basis to medical errors in the U.S. healthcare system. This was an immense number, and everybody was shaking how high it was. The medical errors were actually not secondary to knowledge deficits, but they were secondary to so-called human factors. Human factors may involve teamwork issues, communication problems, falling into routine, and simply forgetting to double-check things. I was obviously glad that I did not make my patient become one of the statistics in the Institute of Medicine report. It is crucial to work on the improvement of the healthcare delivery system. We must strive to make it as fail-safe as possible. The scaffolding of how this immense feat in medicine can be achieved can be taken from other industries, which on the surface are very different than medicine. Look at the aviation industry, for example. Look how the aviation accidents are handled. Each time there is an aviation incident, there is a formal investigation by National Transportation and Safety Board or another national board. This brand new aircraft, a Lockheed TriStar with 176 souls on board, was on its final approach to Miami International Airport when the nose gear control light failed to illuminate. The three pilots were so nervous and frustrated that they actually failed to maintain the proper altitude, and they eventually crashed into Florida Everglades wetlands, killing the majority of the passengers on board. From that time on, the training of pilots has changed and has been revolutionized. In aviation, there is a moral of every mishap story which gives suggested system improvements in the future. This is one of the things that must be instituted in the healthcare system. It's called the new safety culture. If and when doctors, nurses, paramedics make mistakes, you actually ought to learn from their errors. But can you learn lessons from mistakes without jeopardizing the patients? Yes, right here. This is what a medical simulation lab looks like. Here, students and doctors train to maintain their critical thinking ability and to remain focused while dealing with the immense stress. Nobody will get hurt here. The mannequin can be revived instantly. For instance, one of the simulation scenario is transfusing the patient with the wrong blood type. They have to figure out how to prevent the situation. They have to stop the transfusion. They have to create an incident report. They have to administer appropriate medication, and they even have to talk to the patient about what happened. Each year, thousands of nursing and paramedic students run through the medical simulations, trying to improve their skills and knowledge after the rotation. And I've seen it myself. After this rotation, the brains change. They don't think the same way before they came to the center. Each one of them will fail several times during our intense scenarios. During a video feed playback, they can work on improving their performance, and our facilitators will tell them how to improve their performance in the future. I remember not too long ago watching a young physician administering a dose of epinephrine 1,000 times more than required, causing the patient to fall into ventricular fibrillation and eventually expire. I vividly remember watching her trying to be calm and composed after realizing what she had done. Despite her efforts, it was obvious to me that she was falling apart inside. Of course, she was terrified, disappointed in herself, remorseful for her oversight. Who wouldn't be? "I killed my first patient today," she exclaimed. "I will never forget this." And I want you to imagine this unfold in front of you, seeing a physician realizing that a single and simple human error costed this patient's life. Fortunately, this happened in a simulation center and nobody was hurt. The mannequin was actually revived 2 minutes later. We may have killed one mannequin that day, but the lessons learned by everyone in this scenario will go on to save countless lives in the future. Simulation in medical education has been growing rapidly, and it's here to stay. Just as we cannot imagine a captain of an aircraft that we travel in not being trained in an aviation simulator, I can't imagine in 5 years from now any practicing doctor, nurse, or paramedic not being trained in a simulation lab. So did my incident with the chest tube change something in my practice? Yes, it did. From that time on, I've been putting an X sign on the skin of the side of the patient that I treat. Since then, I haven't done a wrong side surgery or put a drain on the wrong side. I learned the hard way, so you and other medical professionals don't have to. Thank you.